Hello, I'm Carl Svedberg from the University of Gothenburg. This is EHJ Today. I'm here in Chicago together with Professor Chris Granger and Professor James Jolly, both from Duke University. We're going to talk about a program that they have initiated and conducted, the Mission Lifeline STEMI. So, Chris, what's this program?
Well, thanks, Carl. So this is an ambitious program that we've embarked on, and it's based, of course, on the fact that coronary heart disease, the #1 cause of death and disability in the world, and acute MI and STEMI, the acute manifestation. And then the most important way to improve survival for acute MI is effective reperfusion therapy. Primary PCI when it can be delivered quickly, and fibrinolytic therapy when primary PCI cannot be delivered quickly. And so the big challenge then is to apply that most effectively. And in order to do that, we've learned, including from the important work that's happened in Europe, for example, in Denmark, the DYNAMI 2 trial, in Sweden, the work that Lars Valentin and others have done with the registry and with implementing effective primary PCI, that one must work with emergency medical services and networks of hospitals in a coordinated way and measure the performance, analyze it, and then feed it back to the key participants, to the stakeholders, in order to improve care. So in the United States, there's been a program that the American Heart Association has led called Mission Lifeline, and it's focused on how we can do this mostly at an individual hospital level, a PCI center. How can the PCI center work with surrounding hospitals and emergency medical services to improve timely reperfusion care? What we did in this program is we went to the next level. And this is particularly important in the United States, where our healthcare system is fragmented. And so what we did is we went into 16 regions in the United States, places like New York City, Atlanta, Houston, big areas, complicated health systems. And we included 484 hospitals, 1,300 EMS agencies, 23,000 patients with STEMI in this program. And so our goal was to establish measurement and feedback using the Action Registry Get With The Guidelines data collection and analysis tool. And then we brought together emergency medical services, hospital administrators, interventional cardiologists, the stakeholders with the American Heart Association, and developed strategies to implement more effective primary PCI, beginning in the pre-hospital setting, right through the reperfusion therapy across these regions. So
did your measurements include actually the quality of the treatment as well, the in-hospital therapy or in the lab?
It did. It included, we've included in the registry, we include all the various elements, including medical therapy, the application of primary PCI, but perhaps for this program, the two most important features are reperfusion and timely reperfusion.
Okay, sounds like a pretty big program. So, James, tell us, what did you find?
So we engaged 16 cities. Chris was talking about New York City, Atlanta, Houston, very large regions. And over a period of a rolling 18 months, we enrolled 23,800 patients. And of those patients in the United States system, we think of them coming in 3 different ways, either by EMS to a hospital that does angioplasty, or they drive to the hospital that does angioplasty, or they're transferred from another facility. Each one of those has targets that are very similar to the European targets. We start the clock when the medic gets to the patient rather than when the EKG is done. So we start the clock a little bit earlier. Our goal is 90 minutes. And what we found overall in these 16 regions with these many patients, we increased the rate of reaching our target goal significantly, modestly, about 3 to 5% depending on the measure, from the beginning of the intervention to the end of the 18 months. That being said, there are some regions that went much quicker. Our top 5 regions, we see improvements up to 20% in an 18-month period. And overall, for the top 5 regions, maybe a 12% difference in hitting guideline goals. So really huge changes. And what we've done here, it's not an intervention that is short-acting. We've actually changed the standard of care. So in some of these cities now, all the paramedics know, here's how we define a STEMI, here's how we treat it, here's how we activate the cath lab. And the cardiologists know on the other end, this is what's coming in, this is how we treat it. So it's a very coordinated and a new standard. It's all based on guidelines, based on a lot of work from Europe and the United States in treating these patients. Then the other real big question is, does it make a difference in mortality? For some reason, so Reimer and Jennings at our institution decades ago showed that the longer you have a occluded artery, the larger the infarction. And that has played out to all of our work over the years, thinking that time critical, the faster you open that artery up, the less damage, the better people do. Somehow there's been this question in our country, does time matter? And so we looked at that specifically. It's an observational study. It's somewhat confounded that sometimes people take longer to be treated because they're busy dying. But we did look at this measure called emergency department time. So in this country, you come through the emergency department from when they enter the hospital to when it got to the cath lab. If the medic, the ambulance, was coordinating with the cardiologist, it was a very short time in the emergency department. If they weren't coordinated, they were waiting down there. And we saw for under 30 minutes, in-hospital mortality was about 3.5%. For a 45-minute wait or longer, in-hospital mortality was 10%. So huge differences. We put it into models, the action model we added in cardiac arrest, and it's still significant. Obviously, it's still confounded. You can never adjust for that kind of delay in observational data. But we get a very strong signal that time is hugely important, and coordinating between paramedics and the cath lab is a very important step.
So how did you feedback or update the organization with your ongoing findings? That must be a huge task too.
So that was the bulk of our work actually, was we were committed to collecting data in the Action Registry and giving regional reports. So for instance, in New York City or Atlanta, we actually showed every hospital letter-coded, as well as the whole region, all these measures, and they could compare themselves knowing who they were. And that really changed care. And then we had this President Johnson that said that it's better to have everyone inside the tent working on a project and outside the tent not collaborating. And we found that when we had a few hospitals working with us, they all joined us. And it really was, I think, the essence of working in a competitive system like the United States to make things work better.
And the other thing that we did see, Carl, was we did see over the course of the project that there were numerical improvements in survival in the regions that we were engaged with compared to the regions that were not engaged.
Okay, very interesting. And as you indicated, we have an experience in this type of quality improvement in Sweden as well, and you know about the work in that work, but it's this is a much larger scale. So interesting. So tell me, what's coming? What's next?
So I think this is really important because we do see heterogeneity, and some of the regions did remarkably well and made really big improvements, and others it takes longer because it's really changing. It's changing healthcare on a regional basis. It's very complicated. So we've learned a lot of important lessons. We're going to go out and use this as a demonstration project, work with the American Heart Association, leverage the lessons that we've had, and hope that we can become more like Sweden, because I think our healthcare system in the United States is burdened by this fragmented approach where we don't tend to measure and feedback and work in a coordinated way. So this, we think, is a very important demonstration that this can be done, and we want to use this to incentivize others to do it.
Yeah, certainly I think you have at least started on a very complicated program, and I hope you're going to succeed. So good luck.
Thank you.
Thank you for coming.